The largest and bulkiest muscle in the back of the shoulder is the trapezius muscle. Okay? So every muscle anteriorly is a trapezius. Now this is the scapula. I examine above the scapula. You see, this is the trapezoid muscle. The bulkiest muscle in the back of the shoulder is the trapezius muscle. I see this, the fish-like appearance from medial. This is the supraspinatus muscle. So I begin examining from medial, which is fish-like, and continue lateral till the thickness increase. You see. Just palpate the scapula, it is above the scapula. So this is trapezius, below it the supraspinatus. Continue laterally, laterally. You see the thickness is increased. The thickness is increased. You see, this is the thickness, increase. While here, it is small. It is fish-like appearance medially. Continue lateral, lateral, lateral. You see there will be a defect at inferior surface of it. Yes. So continue lateral, lateral. Here there will be a defect. Here there will be a defect here. This defect is called suprascapular notch. Contains suprascapular nerve, suprascapular artery. So we can't do ablation here because here the nerve contains motor and sensory supply to supraspinatus and infraspinatus. This notch, which is seen at inferior surface of the supraspinatus muscle, it is called suprascapular notch. I now continue to examine the supraspinatus muscle. So this is the fish-like appearance. Above muscle is trapezius, this is supraspinatus. Continue to examine laterally until reaching a defect. What is this defect? This is the acromion. This acromion. So the supraspinatus comes below the acromion. But below the acromion, we can't see it because of the shadow of the bone. So this supraspinatus comes below the acromion. Now, continue to examine. How to continue to examine? What its action of supraspinatus? Its action is abduction. So I should do action against its normal action, which is adduction. So ask the patient to put his hand in his jacket. This movement is called adduction for better and dynamic examination of supraspinatus muscle. So when I reaching now below the acromion, you see below the acromion, continue to examine. Now lateral, lateral until reach the acromion. Then continue to examine until reach the superior facet of the greater back surface of the greater tuberosity of the humerus, because it is inserted at the superior facet. Here it is called footprint. You see, this is called footprint. This is the site of insertion of supraspinatus muscle, where at the posterior surface of superior facet of the greater tuberosity of the humerus. This is the acromion. This is the deltoid. Here between this muscle and the deltoid muscle, this black line, you see this is a black line, thin line, it is subacromion subdeltoid bursa. We say that is subdeltoid, but because it is continuous with the subacromion, so-called subacromion subdeltoid bursa. It should be thin line, black line, not contain debris, not increased thickness. So here there is no bursitis. What appear here, the black line, I think someone asked what is the black line. It is anisotropy artifact because my probe not perpendicular to muscle. So now return back for examination of supraspinatus from medial to lateral. Palpate the scapula, it is just above the scapula. You see? The first muscle is the trapezius muscle. First muscle is the trapezius muscle. Below it, which is fish-like appearance, this is the supraspinatus. From medial to lateral, you see the increased thickness of it. So continue to examine laterally. Continue to examine laterally until reaching the defect. This is the defect. You see? You can't see the muscle here below the acromion because of the shadow of the bone. However, continue to examine until reaching the superior facet of the greater tuberosity. Continue to examine until reach the superior facet. This is called the footprint. Footprint. Above muscle is deltoid muscle. Between the deltoid and this muscle is the subacromion subdeltoid bursa. So when there is bursitis, you can do injection here by enter the probe in a plain technique. Like this or like this. With 22 gauge needle, 10 centimeter length. Now, examination of the infraspinatus muscle. Palpate the scapula. It is just below the spine of the scapula. Return back to the mentioned position. So, examination of supraspinatus, its action is abduction. So, I do adduction against its normal action for better examination and make the muscle more stretch and dynamic examination. Now, examination of infraspinatus. What's the action of infraspinatus? Its action is external rotation. So I do against its action by doing internal rotation. What's the internal rotation movement? By put the patient hand on the other side. This the position is internal rotation. Its action is external. So I do internal rotation. So examination below the scapula. Spine of the scapula. It is also fish-like appearance. You see? Continue lateral, lateral, lateral. Until you reach a glenoid. You see? This is the glenoid. Above it, the black line, this is the hyaline cartilage. It should be with good thickness in order not to be, because if it is not good thickness, it is OA changes, it is degenerated cartilage. So this is the hyaline cartilage. In front of it is the fibrocartilage labrum. And in front of it, there will be a defect. I see with better resolution. This is the defect called spinoglenoid notch, contain suprascapular nerve and vessel. But here the suprascapular nerve is only sensory branch, not motor branch. So I can do ablation here. I can do ablation here. So continue to examine from medial to lateral, lateral, until reaching the glenoid. You see? This is the glenoid. Hyaline cartilage, and this is the triangular fibrocartilage in front of it, which is labrum. You see this triangular fibrocartilage. So if there is tear, we only can see the anterior and superior part. Another types of tear can see only by MRI. Here we can only see the anterior and superior part. Here is a defect. This defect contains blood vessels and nerve. Here, because the nerve is very small, it is terminal branch, so not appear by nerve tract sometimes. Because nerve tract is especially for large nerve like median and ulnar nerve. So you see, this is the triangular fibrocartilage in front of hyaline cartilage. So now continue to examine. This is the infraspinatus muscle insertion. Infraspinatus muscle insertion to come here. This is the posterior approach, how to do injection of shoulder joint. I do injection just above this hyaline cartilage and below the infraspinatus muscle, just this space, you see, and not touch this hyaline cartilage because it is very painful. And if I want to do ablation of nerve, I can do at spinoglenoid notch here. So this is the infraspinatus. How I see the teres minor? I just make fanning downward. So this is the infraspinatus, and I just make fanning downward. A small muscle will be appear. This is the teres minor. I just to see. This is the infraspinatus. Small muscle will be appear just below the infraspinatus muscle. This is the teres minor. There is another way for examination of all facets of the greater tuberosity. How? By putting the probe sagittal on the greater tuberosity of the humerus. I put my probe on the facet, posterior facet of greater tuberosity. So 3 axial section muscles will be appear. This is the cranial side, so this is the cranial side. This is the supraspinatus, this is infraspinatus, this is teres minor. I put my probe sagittal on the greater tuberosity back surface. So I see axial section of muscle. This is the cranial part, so this is the cranial part of the right side. This is the supraspinatus, this infraspinatus, this is the teres minor muscle. Now, we should go to anterior approach of shoulder injection, which is called rotator cuff interval. When I examine the subscapularis muscle by putting my probe on the coracoid process, then just make my right side of the probe slightly cranial toward the supraspinatus muscle. You see, there is a back space surrounding the long head of biceps. This is subscapularis. This is biceps tendon. From here is supraspinatus. This is the back space surrounding the long head of biceps is rotator cuff interval. So we can do arthrogram here. We can do injection of the anterior shoulder joint from medial to lateral or from lateral to medial. Again, I should say. When I examine the coracoid process and subscapularis muscle, I put my probe here. I just make my right side of the probe cranially. You see? There is a back space surrounding the long head of biceps, especially appear medial now. This back space. So I can do injection in a plain technique until reaching the needle to this side and do monovisc PRP injection, whether steroid anything. So this is the anterior shoulder approach. posterior we see when we inject just below the infraspinatus and above the hyaline cartilage of the glenoid. Regarding the glenohumeral joint, we say that we can't see superior and middle part, we can only see the inferior glenohumeral ligament, which can see in the axilla. So I put my probe at the axilla. The fold is deep. So you see, this is the humeral head from the right side, and below it is the glenoid. The white line between them, because I should press, the white line between them, just to see. This is the humeral head. This is the glenoid. This white line between them is the inferior glenohumeral ligament. We should press because the axilla is deep folding. So we should press more for examination of this ligament. This is a part of a frozen shoulder, together with subscapularis muscle impingement and coracohumeral ligament. Any other structure you want to see again, please? Any other structure you want to see? Just there's a query. Please ask. So now go to demonstration for every doctor, or any structure you see it is difficult to see or not see well, or you want to see the maneuver, how to see it. It's okay for all?
No, okay.
Okay. When you want to speak. So after that, after Al-Saida company speech, there will be demonstration for every doctor to do exam.